One. Sir, we are live now. Now we can start the meeting.
Yeah, a very good evening, everyone. This is Dr. Asnath reporting from Pulse Pharma. I would like to welcome you all to this very exciting and informative evening with two of our delegates, Dr. Jayant Panda and Dr. Varsha Jagtap. Moving on to what's there tonight. So, in the evening to come, we have a very important session by Dr. Professor Jayant Panda on vitamin D and its importance in various chronic diseases, with an special emphasizing on your levels. So we are not talking about something that is very what I can say, very ancient times. We know that 30 nanogram per ml is something that is known to be sufficient, but we are going something above that. And I think who is better than Professor Jan Panda to let us go through it. And we also have a session from Dr. Varsha Jagtap, who would be taking us to the right intervention of vitamin D to get to that levels. And finally, I would be having a small lecture on our uh, Nanocarrier enter vitamin D3 to get to that levels. So with that, I would have some formal duties in front of me. Uh, First of all, I would like to welcome you all on behalf of Pulse Pharmaceuticals, who is currently organizing this wonderful event. And on behalf of that, I would like to have a Pulse video in front of me. Can we have the video, please?
Pulse, a true reflection of the heart and its functioning.
We,
A heart
we are
that is
not able to see the video
about
actually.
others
Can you please
and passionate
share
about
it?
its work.
Yeah.
Pulse, a true reflection of the heart and its functioning. A heart that is compassionate about others and passionate about its work. A heart that is dynamic yet consistent. A heart that is predictable and reliable. A heart that goes the extra mile to deliver what is expected. Our business philosophy encompasses these very principles. At Pulse Pharma, we feel patients' problems, think, innovate, and do everything that it takes to deliver cost-effective solutions. We have a well-aligned leadership team and a highly motivated functional team to carry out our mission. We innovate and develop products with unique functional characteristics that help us serve our customers' needs better. We develop innovative business processes that help us improve our efficiency and customer experience. We have world-class infrastructure that includes an integrated R&D center and 3 manufacturing facilities that help us develop and manufacture high-quality differentiated products. Our research efforts are focused on developing nanotherapeutics, nutri-therapeutics, and cell therapeutics. Our operational presence is spread across India and 40 countries worldwide. We reach out to nearly 250,000 healthcare professionals in various specialties through our sales team of over 1,000 people and our partner sales force in various countries. At Pulse, we work with a real spirit of Pulse to bring about a positive difference in millions of lives. Because we are compassionate about people and passionate about our work.
Thank you, Raghu sir, for the video. Now I would quickly switch on for the presentation part. So I hope my screen is visible. So a warm welcome again from Pulse Pharma. So again, inviting you to this very exciting program with two of our delegates, Professor Jayant Panda and Dr. Varsha Jagtap. So a few words about my organization, who is currently organizing this event. So regarding Pulse Pharmaceuticals, so we are a patient-centric, innovation-driven, integrated pharmaceutical company with an inclusive growth model. We've completed now 27 years of active presence across India and emerging markets, and we are also foraying ourselves into European markets. We have a world-class R&D and manufacturing infrastructure. This would not be possible with a strong leadership team and operational teams with across all business functions, and we are also leading ourselves into in nanopharmaceuticals and drug delivery research with some of our patented technologies. One of them is equal nanotechnology and with our marketed product Deksel Nano Syrup. We are also strong. We have a very strong presence in medical nutrition through Pulse NutriScience, and we are also pouring ourselves into CAR T cell therapies for onco segment. So with this, I would like to introduce our business philosophy. So our business philosophy is create customer value through high quality differentiated products and services by using advanced and patented technologies. With this, I would now quickly switch on to the introduction of our two delegates. So first of all is Dr. Jayant Panda. So I don't think he needs much of the introduction. He's a modern day great in the field of diabetology. So currently he's holding the position of professor and former HOD in SCB Medical College, Odisha. He is also the Dean of Indian College of Cardiology and Metabolic Diseases. He is also Vice Dean of Indian College of Physicians, along with Vice President of American College of Physicians of India chapter. He is currently holding the chairmanship of FRSSDI of Odisha chapter, and he is a president of Indian Medical Association Odisha chapter. He is also a member of Indian Obesity Research Association, and is the state president of Odisha Medical College Teachers Association. He is also holding the position of presidentship in Cuttack Club, and regarding his clinical research, he has more than 71 national and international publications, along with principal investigations of national and international trials. With this, I would like to welcome Professor Dr. Jayant Panda on the stage. I will quickly move to Dr. Varsha Jagtap, who is also currently a very dynamic lady in the field of diabetology. So she is currently holding the position of assistant professor in endocrinology in Bharti Hospital, Pune, and also running a Jagtap Clinic and Research Center for Diabetology. She has won several awards during her time. So one of that is Dr. Palekar Prize and late Prabhakar Ramdas Sadhale Award. During her time at SID, GSMC, and KM Hospital in 2008. She has also been awarded as Best Paper Award as SECON for Clinical Radiology in Idiopathic Growth Hormone Deficiency, and also she has been recognized as Best Interesting Case Presentation at Amrita Certificate Course during 2011. She has also won the Best Paper Award at ITSCON 2011 for award for her work in as prevalence and impact of thyroid disorders on maternal outcomes in Indian pregnant women. And she has also been awarded as Best Resident in KM Hospital in 2012 during her super specialty. Regarding her clinical research, so a very young but dynamic lady, so has more than 27 national and international publications, and more to come in the coming years. So with this, I would conclude this presentation part and quickly switch on to Professor Dr. Jayant Panda to let us go through the interesting points that he has for vitamin D and its importance in various diseases, along with emphasizing on the importance of levels. Over to you, Dr. Panda.
Thank you, Dr. Harshnath, for that kind introduction and introducing the Pulse Pharma and the today's program. With this, I'm sharing my slide. The slides are visible?
Yeah, sir. It's completely visible. You can just click on full screen.
Yeah. Now it's changing?
Yeah. Yes, sir.
Changing. That's good. So, what I do, let me hide this routing meeting control. That's good. So all of us know how vitamin D came into the picture, how we evaluate, how we assess, and how we treat. If you see few years back, say 10 to 15 years back, this was not there in clinical scenario. And when suddenly a lot of research came correlating vitamin D3, especially the 125 dihydroxycholecalciferol, with etiology, prognosis, complications, and outcome of many diseases, we started evaluating and knew that in Indians it's very low. And by correcting, we got some clinical relief also. And by studying, we could correlate, especially in the metabolic segment with diabetes, with collagen vascular disorders, especially in SLE, and many other conditions of malnutrition and infection. During COVID also, we have used vitamin D3 and we have seen its effect on immunity and outcome. So today's topic, I'll be very brief in next 10-15 minutes, telling you revisiting the right vitamin D intervention strategy for better patient outcome, which includes how we should suspect, how we should detect, establish, start, maintain, and go ahead with vitamin D intervention, and what is scientific and what is not scientific. So with this, I invite all of you to this webinar and thank Pulse Pharma for this opportunity of updating in this field. We know for every action in nature, there is an equal and opposite reaction. We know it right from the Newton's third law of motion. So, keeping this in mind, let us move forward for vitamin D, that every vitamin D level, there is an equal pharmacodynamic effect. So, if it's there, if it is low, if it is high, what happens that we need to see. COVID-19, we know, is known to cause immune dysregulation, and it was a known immunomodulator, and it has been clinically proven for role in the management. And we used to give vitamin D for 3 consecutive days, and it's important for effect and the outcome that has been proved beyond doubt by many others. But there is a unpredictable result during the pandemic, and then in 21, a study showed the vitamin D supplementation leads to significant reduction in the inflammatory parameters that were elevated due to COVID-19 infection. And you know, we did a lot of markers starting from the interleukin, starting from the ferritin, and a study done by the Bulgarian J concluded the vitamin D supplementation doesn't lead to any significant reduction in inflammatory parameters. So these are contradictory studies, and they contradict themselves with different angles. So another study by Rastogi conducted and concluded that vitamin D supplementation leads to only a significant reduction in fibrinogen levels and doesn't lead to any significant reduction in other parameters. Because we trusted that drug, and at that time, any drug which came like hydroxychloroquine, like the immunoregulators that we have used and got it. So the opinion differing in different studies during the pandemic, why this difference with the vitamin D supplementation that was searched for. The importance of levels in COVID-19 is one thing needs to be observed in this trial is post vitamin D levels. So all these studies, if you analyze, the post vitamin D levels were 89 nanogram in the Lucky Reddy study, 23 nanogram in the Bulgarian study, and 51.7 nanogram in the Rastogi study. So here, the changes in inflammatory levels were significant in the first one. There is no significant changes amounting to low level of vitamin D3, and only significant reduction was the fibrinogen level when it was in between. We know that though the vitamin D was used in all three cases, the doses, the amount, and the duration were not equal. So somewhere we got the benefit, somewhere we didn't get any benefit, and somewhere we got some benefit in the form of reduction in fibrinogen level and no significant reduction in D-dimer, procalcitonin, or CRP. So the importance of levels in pre-diabetes management came into picture, and the risk for type 2 diabetes in the people with pre-diabetes with vitamin D deficiency was reviewed, which told the individuals who maintain a mean serum 25 hydroxy vitamin D level of at least more than 50 had a 76% low risk of developing diabetes compared to those with levels between 20 and 29 nanogram per ml, which is a level 1 evidence. So if we maintain it, more than 50 is the level, and we know in the COVID study that we never maintained it more than 50 in the Bulgarian et al. Study. And it is just 50 in Rastogi where we got partial benefit. So the levels in diabetes management is important. It's not that you give 1,000, you give 2,000, 6,000, or you give a injection of 6 lakhs, or you give a 60,000 weekly. So what should be our doses and what should be our intervention modality? Most of the studies in these role in diabetes show an improved glycemic effect on the vitamin D supplementation. The level plays an important role that I have already told, and again sharing the authors. You see, the post vitamin D levels after supplementation varies from 40 to 43.56 to 62.71, and the difference in A1C level compared to baseline also differ. Higher the vitamin D level, better is the reduction of A1C level. You see in the Mehta study up to 2%, and in UN study up to only 0.4%. So all three studies showed that vitamin D supplementation have a positive effect on A1C, but point to note that the level of vitamin D is rising, it leading greater importance in A1C compared to baseline. So it directly proportional to level of rise, and within the normal lipid limit, the more the vitamin D level, more reduction is HbA1c. And again, we'll see in the field of PCOS management, where study by Gunjan Garg in AIMS concluded vitamin D supplementation has no effect on insulin parameters in PCOS. And another study done by the Taru Gupta in association of Federation of Obstetrics and Gynecological, that is FOXY in Delhi, concluded that vitamin supplementation plays a major role in management of PCOS. So why this difference? Here you see the Garg study, the post vitamin D level is just 31.5, where Gupta it's 44.9, and the percentage of reduction of testosterone from baseline is 25% in Garg and 41% in Gupta. So there is no reduction, instead of an increase was found in serum fasting glucose levels, but 6% reduction was seen in the Gupta study. So again, here in the post vitamin D level, the effect of the correction is reflected in different disease condition. And here in the insulin management in the obese, overweight adults, the vitamin D study done at the Shalorpur et al. In 13 showed the vitamin D3 supplementation doesn't improve any glycemic indices in healthy or obese women, whereas here by M.B.B.S and et al. Showed that supplementation improves sensitivity, insulin sensitivity, pancreatic function, beta cell function in the healthy and overweight obese adults. And if you again assess their levels, in Shalapur it's 30, in M.B.B.S it's 38.6. So when the vitamin D is supplemented but not achieved to the normal level, we are not getting the therapeutic effects of the D3. That was the conclusion. So every nanogram per ml of vitamin D counts, and all these three articles show here that the supplementation of vitamin D is beneficial for the improvement of the vascular function in patients with CKD. So here you can see how all good journals have established this the role in CKD. But vitamin D level play a role in the improvement of vascular function or not is a still big question. And here the Chitalia N study, the Vivek study in 18 and 17 shows different levels of vitamin D and improvement in the pulse wave velocity from the baseline. So it's evident from the above table that the every nanogram per ml rise of vitamin D is important for its action on arterial stiffness and measured by pulse wave velocity in CKD patients. So here every nanogram per ml vitamin D can make a difference in asthma patients as well. And if you'll see these studies, the supplementation adjunct to the standard treatment doesn't improve was concluded by Dr. Chirag Thakur and friends. And here the significant benefit was achieved in vitamin D3 supplementation was concluded by Majak, Powell, and others. So again, if you go to the level of post-vitamin D level, there is a difference. And then data shows that 35.5 was not associated with the improvement with the asthma symptoms, whereas very narrow difference, 37.6 nanogram was associated with increase in the asthma symptom. In COPD patients, again, the first study concluded it's beneficial for the COPD patients, and second, failed to show any benefit for the COPD patients. And here, the level is very high or optimal, that is 51.83 in 4-month study. It's just 37.7 in RAFIC study. So from data, it shows 37.7 nanogram, even though sufficient as per the recommendation, not associated with an improvement in the COPD, but 51.83 was associated with the improvement in the COPD symptoms. Now, this questioned the vitamin D levels in the depressive patients, and again there is a difference of no difference in the depressive patients and improves the depressive patients. In Jode et al., it was 34, and Kaviani aim, it was 51.15. So in 51.16 patients, a significant improvement in the depressive symptom as well, and 34 nanogram per ml, even though sufficient as per the prescribed recommendation, was not associated with an improvement in depressive symptoms, but 51.16 was associated with the improvement in the depressive symptoms. So in psoriasis patients, same. Few studies say it did not affect psoriasis severity. Few studies say it's safe. Vitiligo and psoriasis patients should be used. Again, if you do in Janssen, it is 30. In Finamo, it is 106, telling the sign of there's no sign of toxicity, but no improvement in the PASI score in case of Janssen, where the vitamin D score is low, that's 30. In psoriatic patients, the 30 gram per ml which was achieved, and the study highlights the significant inverse relationship between PASI and the vitamin D3 was challenged, and this shows that the effect to start visible effect after a level of 50 nanogram per ml, and significant improvement is found. So if you ask me, the levels should be optimally more than 50. Though up to 100 we take as normal, less than 20 we take it very low, 20 to 30 we take as optimal, but still all these situations we show where the vitamin D is less than 50 or around 30, 35, it is not working as per expectation. And vitamin D levels on Treg cells, again, the pretty B study is 58, and MAPSI W study is 32. And in 32 MAPSI study, no impact on the expression of the Treg expression. And this has been shown to have no Treg expression, which is important for anti-inflammatory action of the vitamin D. And 58 is shown to have a positive impact on Treg expression, thus exerting anti-inflammatory actions. Here in the interferon gamma, the JAGI shows 50 and the MABOSE shows 32, and it just with 32, it 28% decrease the INF gamma expression, and with 50, it's 40% decrease in IMA gamma expression. So level of 50 nanogram vitamin D has shown exert a greater and potential inhibition of the interferon gamma expression compared to 32 nanogram per ml. in cathelicidin expression, again, Sharifi study 41 and M.B.B.S study 36, which just shows 1.2-fold increase in cathelicidin expression, where this Sharifi shows 3-fold expression of cathelicidin expression. So antimicrobial peptide, the cathelicidin expresses, it has shown to increase with increased serum vitamin D levels, and a significant increase in the cathelicidin expression in 41 nanogram per ml compared to 36 nanogram per ml is seen over here. Let us see in epigenetic modulation. So this study by Shibani A in collaboration with Michael Hollix. Michael Hollix, you must be knowing, is the discoverer of vitamin D, and he is very passionate, and most of the work and publications are done by him, and reported difference in the gene regulation that are involved in the cell proliferation, differentiation in the immunity by the different levels of vitamin D, and studies showed that 25-hydroxy D level of approximately 78.6 nanogram per ml has shown to increase the genomic expression of the genes involved in cell proliferation, differentiation, and immunity by more than 4-fold compared to level of 40.9 nanogram per ml. So the risk of toxicity and acceptable level we see, because we know it's a fat soluble vitamin, and at times it can have its overdose toxicity, and up to what level, up to what sub level of supplementation, we are sure that there will be no intolerance. The level is, as I told you, is 30 to 100 nanogram per ml, and found to be acceptable under many guidelines without any risk of hypocalcemia or hypercalciuria, the risk of kidney stone. So the toxicity and acceptable level, only few articles actually correlate the vitamin D with hypocalcemia. On this point, recently published data shows the relation of vitamin D levels with the hypocalcemia. You can see here the mild hypocalcemia, here 23.2% right side and 15.2% left side, and the normocalcemic area is the rest except that. So 84% patients with 25 hydroxy vitamin D3 levels more than 88 nanogram per ml were normocalcemic, followed by around 15% with mild hypercalcemia, and only 0.6% and 0.4% with moderate and severe hypercalcemia, respectively. Here, the 75% of patients with 25 hydroxy level more than 150, here it was 88, were normocalcemic, followed by around 23% with mild hypercalcemia, and only 1.8% with moderate hypercalcemia, and no case of severe hypercalcemia in individuals with 25 hydroxy levels more than 150 nanogram per ml. So the toxicity and acceptable level, if we see, it's the studies show that when it has not crossed 100, we don't have toxicity, and when the level is below 50 nanogram per ml, the levels are not achieved beyond 30, and the patient doesn't have the therapeutic effect. It has shown that the incidence of 25 hydroxy vitamin D levels above 80 nanogram increased significantly between 2002 and 2011 without a corresponding increase in the acute clinical toxicity. No significant increase was found in their incidence, and in this study, one case of toxicity of hypocalcemia was found due to elevated 25 hydroxy vitamin D3 levels. So the conclusion is important for following points: a significant positive trend for traditional 30 nanogram per ml in 2002 to 50 nanogram ml and 80 nanogram per ml in 2011, and a positive trend, although insignificant, towards the incidence of 100 nanogram per ml and increase to 5,000 50, 80 or 100 nanogram per ml is not related to any hypercalcemic toxicity. One side effect was reported that was at an abnormal level of 364 nanogram per ml. So when we're keeping a target of 50, 80 or 100, the therapeutic response is more, and side effect of toxicity is not there. So here again, it's concluded in monthly high dose vitamin D supplementation, which doesn't increase kidney stone risk in the serum calcium, results from a randomized controlled trial by Jarintas Malihi, and over a median 3.3 years monthly supplementation with 1 lakh international unit vitamin D3 did not affect the incidence rate of kidney stone or hypercalcemia. So the final level of around 80 nanogram per ml was found in patients up to the end of 3.3 years. So the current available cholecalciferol preparations are in tablets, in soft gelatin capsules, in oral disintegrating strips, oral spray, oral solutions, intramuscular injections. And there are many cholecalciferol preparations available in the market of different pharmaceuticals. And are they same or are they equally potential? You can give weekly, or you can give daily, or you can give in an interval like 3 months or 6 months. So what is delivered is not promised is evident from here. We see the tablets, sachets, and different doses are mentioned here. The actual dose of cholecalciferol is shown, and then the range by the Indian Pharmacopoeia is shown, and percent deviation from the claimed strength is shown. So though we detect it, though we try to treat it, because the suggested range by the Indian Pharmacopoeia is there, but hardly we reach there, the deviation is more and therapeutic effect is not there. So high degree of variability in vitamin D3 content of various formulation in India is seen, and the conventional formulation of vitamin D3, the absorption, the bioavailability, the compliance, they all are affected by multiple criteria. Even and then if they are not maintained in the standard condition, the absorption, assimilation, and increase in vitamin D3 doesn't take place. Especially people with bowel disorders and people with poor absorption, people with different metabolic conditions. So the limitations of the oral vitamin D3 formulation are largely depend upon the lipid absorption pathway for their absorption, needed to be taken with ghee, milk, curd, butter for the better absorption, poor and inconsistent oral bioavailability, in compromised lipid absorption, the bioavailability from these formulations and are questionable. And here the vitamin D is absorbed by the lymphatic system, and physiologically a large inter and intra variability which have been seen with the vitamin D absorption, and the formulation related challenges like difference vitamin D formulations have been shown to have different bioavailability. So to summarize, recent shreds of evidence suggest that a level of 30 nanogram ml provides no better or minimal benefit over the placebo in chronic disease conditions. Going above 30 nanogram per ml to a level of 50 nanogram per ml is proven to be beneficial in most diabetes, PCOS, obesity, asthma, COPD, and depression patients. Above 80 nanogram per ml for musculoskeletal disorders and autoimmune conditions, they are effective. So the guidelines suggest that the hypervitaminosis occur above a level of 100 to 150 nanogram per ml, and evidences highlight that severe hypercalcemia doesn't occur even at the level of 150 nanogram per ml. So vitamin D, being a fat-soluble vitamin, encounters the absorption problems via the both physiological and formulation-related challenges for its absorption. With this, ladies and gentlemen, I'll conclude. Just detecting hypovitaminosis D3, giving some supplementation without monitoring and targeting the level doesn't benefit our patients. So you have to know that 50 is the optimal level where the patient can benefit the vitamin D treatment. And if it goes a little high, 60, 70 also, there is no harm. And the toxicity comes only more than 100 or more than 150. And if we give the preparation in a liquid form, in a tablet form, in a capsule form, in an injectable form, in a nano form. We have to be sure that the route is proper and our injections are working properly. So if you monitor that, you see the post vitamin D3 levels and titrate it and give in the different routes guarding in the patients, we can achieve the level which is medically significant, at least 50 nanograms, and there we can get the benefit also. With this, I thank you again for your time, and will be happy to conclude here, taking questions if any, till Madam Varsha Madam completes her talk, or at the end we can take the questions. Thank you all.
Thank you, Dr. Panda. I think it was such an elaborative session. We'll take some questions, and of course, we'll have some discussion at the end. Now, I would like to again reintroduce Dr. Varsha, the lady from Pune for diabetology. So I think I already had a brief, a brief introduction of yours. I think you missed that introduction. Anyways, I think Dr. Varsha is doing a fabulous job in Pune with Bharti and of course her own clinic, Dr. Jagtap clinic. So I think this is some few words about Dr. Varsha, and as I said, she has won a lot of prizes and awards during her time in specialty and super specialty. Now, without wasting any further time, I would quickly switch on to Dr. Varsha to take us through some of the guidelines and what the routine regime is. So over to you, Dr. Varsha.
Yeah, thank you for the introduction. So just a moment. Right, are the slides visible?
Yeah.
Yeah. So a very good evening to all of you, and it's going to be a very interesting discussion, especially after Dr. Panda's talk. And I will be playing the devil's advocate here, and I will be giving a contrasting view. And let's see how things progress. So, if we were to talk about vitamin D and how vitamin D, we all know, is a hormone, and it's called as a sunshine vitamin also. This is actually the basics of vitamin D, that it gets produced under our skin because of the ultraviolet B radiation. The UVB radiation converts the dehydrocholesterol to pre-vitamin D. And then the pre-vitamin D is basically, converted to vitamin D, which then has got two steps for activation. The first step is in the liver, where it is 25-hydroxy D forms. And then the second activation takes place in the kidneys, where 1,25-dihydroxy D forms, right? And we all know that 1,25-dihydroxy is under the regulation of PTH, calcium, and phosphorus. So this is what is again shown in this particular cartoon, that, from 70-hydroxycholesterol, you have the cholecalciferol or the vitamin D, which then in the liver is 25, and then in the kidney is 125. So if we speak about the skeletal and extraskeletal effects of vitamin D, then I guess the extraskeletal effects of vitamin D have all been, covered by Dr. Panda. He was talking about how it is useful in conditions of insulin resistance like PCOS, type 2 diabetes, how it is useful in conditions of, where it is going to increase the immunity as it did with COVID times, or in the cardiovascular diseases, or in the, it is going to prevent mitosis, prevent inhibition of cell proliferation in cancer, and how it is helpful as a neuroprotective agent also. But when we talk about these extraskeletal benefits of vitamin D, then we need to understand that these are all benefits which have not been proven without doubt. So if there are 3 studies to tell you that, okay, it worked, there were 3 studies to tell you that it did not work. And yes, as has been highlighted, vitamin D levels, which are in a level which goes above a certain range, was helpful for the extraskeletal benefits. When it comes to skeletal benefits, then for bones, the optimal mineralization, via calcium phosphorus handling for vitamin D can happen even at a range about 20-25 nanogram per ml, right? So I would say that the Doubtful effects are on the extraskeletal system. The effects proven without any doubt, the effects which we don't really have any controversy about, are the skeletal effects, and which we all know that are important for maintaining the musculoskeletal health. Now, if we talk about vitamin D deficiency prevalence, then it is widely prevalent. 75%, I would say even more than that, are deficient. And young adults below 25 are the ones which are most affected. And if you look at different age groups, adults, infants, pregnant, lactating women, and across India, from Kashmir to the south of India, like Tirupati and Mysore, near to the equator. But we can see that all across, the vitamin D levels are on a lower side, and vitamin D deficiency is very, very prevalent. And majority of us have vitamin D levels below 20 nanogram per ml. And if we look at what are the guidelines recommending, right? So now if you highlight here on the UK US guidelines, then this is now in nanomoles per liter. Okay, so this is not in nanogram per ml, but this is in nanomoles. So if you look at UK, then they say that deficiency is below 25 nanomoles. So now nanomoles or 25, so roughly you'll have to divide it by 3 somewhere. So less than 8 or 9 would be ng per ml. So that kind of level, right? So that is the UK definition to call it as deficiency, and sufficiency is about that. Now that you would find it quite low if you look at the IOM or the Endocrine Society guidelines. The Endocrine Society guidelines say that a level of deficiency is below 50. That is below 20 to 30 is insufficiency, and more than 30. Now I'm talking in nanogram per ml. Those are the sufficiency levels, right? So these are the recommended guidelines by these different societies across world. Okay, now if we talk about the dosages and duration as to how long you want to treat, then if you're treating a symptomatic patient, so you have hypocalcemia, you have rickets, you have osteomalacia, you have a person who is, say, on n number of other drugs leading to osteomalacia, then obviously such a patient you're going to treat to the target, right? So you're going to treat that patient with starting with 60 per K for 12 weeks. Okay. And if unsatisfactory response, you're going to repeat it, right? And you're going to then maintain it after achieving the levels by giving it once a month. For those people who are just insufficient, so in the range of 20 to 30, and where they do not really have any symptoms as such, then these patients can also be treated with a daily dose and need not be actually loaded, asymptomatic patients. But those who are symptomatic and are in the 20 to 30 zone, then we can treat them with a weekly dose for 8 weeks and thereafter then maintain it by once a month. So what I'm trying to reiterate here is that these dosages are not same for each and every person. Okay, so you have to decide why are you treating a particular patient. So just because the patient did a level of vitamin D and came to you, okay, is that the reason as to why you're treating the patient, or the patient landed to you for symptoms which were due to vitamin D deficiency? Okay, also if there is an underlying obesity, if the person is receiving any other drugs like anticonvulsant drugs, if the patient has got malabsorption syndrome, if the patient has got CKD, if the patient has undergone a bariatric surgery, then looking at all these parameters, you'll have to choose what dose, what kind of vitamin D to be given, right? Suppose a person is having malabsorption, then giving them oral vitamin D might not actually do the job, right? So you might have to give this particular patient a injectable vitamin D. Someone who's got a renal disease, then giving them only cholecalciferol might not work, because it does not get activated. So you might have to give this particular patient a activated 125 form of vitamin D. So depending upon what kind of patient you are treating with, and depending upon, what is the symptom of the patient, you might have to tailor the regimen for your patients. So now here comes the major part of my talk. I think this is going to be new for majority of us here. These are new guidelines from the Endocrine Society. These have not yet been published. They are available ahead of publication This is in JCM 2024, August, that it will get published. And here we are talking about with vitamin D for prevention of disease. Now, please understand, they're not talking about vitamin D for treatment of vitamin D deficiency. No one is going to argue about that. If you have a patient presenting with symptoms of vitamin D deficiency, like rickets, like osteomalacia, like other, skeletal problems, or if the person is presenting with hypocalcemic seizures, obviously you're not going to talk about there. It goes without saying that you want to give vitamin D to the patient to a level so as to ameliorate the symptoms. Here, Endocrine Society is talking about vitamin D for the prevention of disease. So, as was talked about earlier, so now there are studies which have been shown in the previous presentation. There it was told that a vitamin D level of 80 will prevent PCOS, a vitamin D level of 100 will prevent you from getting into complications of COVID or complications of other COPD and so on. So, do we really target those levels in our routine patients? What is the evidence for that? And what do we do in our practice? So I will not be discussing the entire paper. So this is the summary of the paper. So they, after going through all the evidence, Endocrine Society came up with this guideline that in the age group of below 18, okay, so in the age group of below 18, then you need not really check for vitamin D levels and you can empirically give vitamin D supplementation. And why do you want to do that? Because that's the age of the, a bone, what do we call approval? That's the age that where a person is actually going to increase the bone mineral density, right? And so to prevent nutritional rickets, so empirically vitamin D is to be supplemented and the dosages are given below 300 to 2000 IU per day in that particular age group. If you look at in the age group of 19 to 74, then there is no role of empiric vitamin D supplementation. So what do we mean by empiric vitamin D supplementation? That means you have not done the level, okay, but you're empirically treating the patient with loading dosages of vitamin D 60K and then going on, treating for weeks and then thereafter giving a maintenance dose. So these are patients who are asymptomatic, who are not having any symptoms suggestive of vitamin D deficiency or of suggestive of hypocalcemia, and they are coming to your routine OPD. Then how much vitamin D should you give them? So the ones which are given here in the figures, these are the recommended daily allowances, right, for that particular age group. So 600 IU per day in that age group of 19 to 74 is sufficient. As against this, as you get older and older, so the seniors above the age of 75, there it has been shown to have the potential of lowering the risk of mortality. And here the units as high as 400 to 3000 units IU per day can be utilized empirically without checking the vitamin D levels and actually treating them. Now, two different subgroups were also studied, pregnancy and prediabetes. So in pregnancy, again, we need to empirically supplement with vitamin D because we want to lower the risk of preeclampsia, preterm births, and neonatal mortality. And the vitamin D dosages can be used at anywhere between 600 to 5000 IU per day without any risk of any adverse events. And as the data was shown, yes, the evidence for preventing the conversion from pre-diabetes to diabetes does exist for empiric vitamin D supplementation, and hence in these particular subset of patients we can use a dose of somewhere around 842 to 7500. Now why these weird units? Because they have been converted from the SI to the conventional units. So these kinds of IU per day can be utilized for the pre-diabetic patients. So just to summarize, below 18 up to 2000 IU per day, 19 to 74, 600. More than 75, you can go as high as 2000, 3000. Pregnant ladies, again, you can go anywhere up to 5000. And in pre-diabetic range, you can go give a dosage of 1000, 2000, 3000, even up to 7000 IU per day. Now, So after going through all the evidence, Endocrine Society actually said that if we are not treating any symptoms of hypocalcemia or vitamin D deficiency presenting features which the patient does not have, then you no longer need to endorse a particular level of vitamin D. So you don't have to reach that target of 30 and 20 for a otherwise asymptomatic person who does not have any of the other parameters that we talked about. That means the patient is not pregnant, is not pre-diabetic. Then you need not really, look at the levels and try to reach that particular level. Uh, so this is what was actually there in this guideline. I'm more to open to discussion, so we can have a fruitful discussion and discuss as to why these guidelines actually came about.
Thank you, Dr. Varsha. I think you have countered Dr. Panda, and we'll have a brief discussion on this thing. It would be very elaborative, and I think I would be learning a lot from them.
Right. So before we actually go on to the discussion, I do get the evidence that vitamin D level beyond a particular range of 80 and 100 is helpful for the extraskeletal benefits. But we need to understand that the balance is very difficult to achieve there. In our practice, I think Dr. Panda would also agree that we have had patients of vitamin D levels of 80 and 90 being admitted for hypocalcemia. So in real life, it is very difficult to a vitamin D test costs you 1,700 rupees. And a pre-diabetic patient coming to me is actually even crying for doing a HbA1c. So, so I have to, so how many times do I check the vitamin D levels? How many times do I check the calcium levels? So the benefit for extraskeletal is there, and it should still be there in the research setting. So if the patient is in a research setting, yes, you are doing it. You are trying to see what happens to but when it comes to your routine clinical practice, vitamin D is being treated for the skeletal benefits, for extraskeletal benefits. Pre-diabetes, agree that the evidence is there, and yes, that can be one of the indication and maybe with time, as the evidence increases further and further, as our vitamin D gets cheaper and more accessible to our patients in terms of testing, we can do it more often.
True. I would quickly switch on my PPT. I have a brief PPT for the you both have spoken wonderfully for the pharmacodynamic part. I would just quickly take the audience to the pharmacokinetic part. I hope my screen is visible.
Yes, it is.
Yeah. So I would quickly take you all to the pharmacokinetic part of vitamin D. So I think Dr. Panda and Dr. Varsha has rightly put on this thought that there is a need to deliver the vitamin D3 orally, as Dr. Panda mentioned in the slides, that the absorption of vitamin D is variable among people, and secondly, it is physiological as well as having some formulation related aspects that needs to be addressed for its absorption. So thus, Pulse Pharmaceutical has taken this initiative and has made a wonderful product known as Nanocarrier Entra Vitamin D3 to enhance oral absorption of vitamin D. So this is a patented product of Pulse Pharmaceuticals with the marketed name of Deksel Nano. So I will quickly go on for the features. So unlike any other traditional formulations, Nanocarrier Entra Vitamin D3 does not depend upon the lipid digestion process for its absorption. So, secondly, it shows a rapid gastric emptying, thus improving the rate of absorption. It is also doesn't get affected by harsh GI conditions, including pH and enzymes. It is unaffected by fat-fast variation, and hence it has predictable oral viability. And because of its small size and surface charge, Nanocarrier Entra Vitamin D3 accumulates in the mucus layer and it gets entered into the unstirred water layer due to its hydrophilic surface. And it is also transported due to its small size of less than 150 nanometer. It is transported across the enterocytic membrane via several mechanisms and thereby increasing the absorption. Now, I would just take you through the part here, the technology part. So Nanocarrier enter vitamin D3, you can see the structure here. It has a hydrophilic layer. It has a nanocarrier entrap vitamin D with a layer of pH resistant and enzyme resistant, and also a zeta potential. So what does this mean? So hydrophilic layer, so that it helps to pass through the mucus unstirred layered in near the enterocytes. You have the lipid nanocarrier, and of course you have pH and enzyme resistant barrier to make it stable throughout your GI environment, and a zeta potential to make it stable, to do not actually not to make it stable, but actually to not form agglomerates in the suspension. So we are one of the organizations that is having a shelf life of 24 months. So that is because of this wonderful technology of zeta potential. So we are one of the few organizations that have done tremendous work on vitamin D, and I am feeling very honored to be given this opportunity to present some of the trials in front of you. So we have done around 7 trials, but I would just like to present few of those. So this is one of the trial that has been done against capsules and granules. So what was the dosing schedule? The dosing schedule was Nanocarrier enter vitamin D3 per Pulse Pharmaceuticals, Deksel Nano Syrup, 60,000 IU once a day for 10 days. Capsules was given 60,000 IU once a day for 10 days, and granules was given once a day for 10 days again. What was seen? If you see, the highest rise was seen with Deksel Nano Syrup after 21st day. So we have given it for 10 consecutive day, and the measurement was done after at 21st day. This is one of the reason that because of the half-life. So we have taken one half-life and we have taken it at 21st day. So you can see the highest increase was seen with Nanocarrier enter vitamin D3 against capsules and granules. And this shows that Nanocarrier entrap syrup formulation was significantly better than others, and there was no signs of hypercalcemia was reported at 96. I would quickly move on to the next trial, that is against intramuscular injection. We have just completed this trial and we are about to do the publication part. So again, Nanocarrier entra vitamin D3 was given for 60,000 IU for 10 consecutive days, and intramuscular injection was given 6 lakh IU at the start of the treatment. What was seen? You can see the highest rise was seen again with Nanocarrier entra vitamin D3 at day 10 as well as at day 30. So you can see the myth that is around the globe that intramuscular injection gives you a faster rise. That is not true. The ours has given a faster rise at day 10, even at day 30, ours is far superior as compared to your IM injection. What was noted? The rapid correction was done with Nanocarrier enter vitamin D3 compared to IM injection, and thus no signs of hypercalcemia was reported even at 71. This is very evident because in the previous trial, even at 96, we didn't get any hypercalcemia. So at 71, it was bound to happen. So this is 2 of the trials that I wanted to show. I would quickly move on to. So I would quickly move on to this thing, that when the patient is in need, the time is our prime, and why to wait for 12 weeks to get to the desired vitamin D levels, because the current regime is 60,000 IU for per week for 12 weeks. So why to wait for 12 weeks to get to that optimal, or that 40 or 50 nanogram per ml, when you can get it via continuous therapy? So this is something that Pulse has taken an initiative to help the patient and the physicians. So we have taken this initiative to do the trials across the indications, and we have found out that 60,000 IU given continuously helps you achieve the results far superior as compared to your weekly therapy. So we have 3 dosage regimes here. First is 10 days continuous therapy. So 10 days continuous therapy will give you a rise of around 96.75, which we have already seen in the first trial. Then we have another trial for 7 consecutive days that goes to a level of around 51. Then we have 5 consecutive days that goes to a level of around 45. So continuous therapy will lead to a level of around 45, 51, and 96 with 5, 7, and 10 days respectively. So with this, I would again like to thank you all for this, for your continuous attention. Now I would stop the sharing, and now we can have some good discussion with the doctors, and I would also like to take some questions if any. So yeah, Dr. Panda and Dr. Varsha, we can have some discussion now.
Yeah. Actually, a very interesting fact, very interesting session. Dr. Varsha has rightly told the approach, and what I'll summarize is the last word has not been uttered in the vitamin D3 therapy. As I told a few years back, 10, 12 years back, it was not there in scenario. And then we investigate the patients in different indications, skeletal and the extraskeletal, metabolic, and we get the pictures of varied type, and few, as I showed, few get the therapeutic benefit, few don't get. And even if there is arbitrary division of insufficiency, sufficiency, and toxic, the levels vary in different ethnicity, different countries, different group of people, different age group, different indications. So the last word has not been uttered. So now we have to note our observations, but in our practice, we have worked, we have published papers, and we have seen in different indications, the immunological, the rheumatological, the metabolic, the skeletal, where we have seen a 30 nanogram usually doesn't suffice, and people who have maintained 50 nanogram, they have got a optimal therapeutic benefit. Above that, I'm 100% agreeing with Dr. Barsha that the hypercalcemia need to be evaluated, and you have to see the safety part also. So it all depends how you fix your target, and time to time evaluate patient for the safety, toxicity, and necessity at all for the supplementation. And only time will answer, as she has told. The Endocrine Society has also withdrawn the guidelines there, because there are not many confusion in this guidelines in the different parts,
Oh,
different countries, different societies. But it is for sure we Indians are deficient in vitamin D3 level, and by correcting, we get a moderate clinical benefit. But how much, how long, and when to stop? There are many questions to reply.
yeah. Yeah, Dr. Varsha, you can add to some of the things.
No, I agree. I agree. So it is yet, as he said, it is quite unclear, and maybe more and more data will add to our knowledge and further change the guidelines.
Yeah, I will quickly move to a very basic question to both of you. That you being a more senior person than me, what were your thoughts during your academics and during your practice? Because what I have seen through my academics, be it my bachelor's or master's or even my doctorates, that vitamin D was a vitamin and never was thought as a supplement. Was never was thought as a therapy. But during my doctorate, I've seen patients actually coming up, and the algorithms were set for vitamin D, that this patient needs to take vitamin D. So it was inculcated into the algorithm. I want to hear from you too, that what was your what you say thoughts during your academics and how you have progressed with vitamin D in your practice.
In a lighter sense, I'll tell, if you are not getting anything in your patient, advise vitamin D3, and the patient will also detect from his or her side, sir, mera bahut kam gaya hai, and will be happy taking vitamin D3, and not will not blame you for treating with vitamins only, or treating a functional disease. So
Yeah.
you can, anybody, you want to brand a vitamin D deficient, you advise it and manage him with vitamin D3, the patient will be happy and you will be happy, because the final thing is not known how it works, when it works, and when to correct, and how long to go. Now, when I don't find anything, we get few patients who are functional, like conversion reaction, and they don't have any physical abnormality. There, we end up with a few mood elevators and vitamin D3. That's what we are doing. And Dr. Barsha will tell her experience.
No, I agree. So basically, as you said, over the years, what I've seen is that, and rightly so, that we need to emphasize about this rampant use of intramuscular injections and weekly ones, which is the practice which goes on for what many weeks, I don't know, and then it just continues thereafter. So I think with the pharma support and with the oral vitamin D being, and you're giving the right message that it does increase the vitamin D earlier and actually better than the intramuscular. So you're dispelling the myth there, and I think that is a good knowledge which should percolate across the physicians and the other general practitioners.
True. Now moving to a very, what you say, now a debating thing that I would take up now, the importance of level. Now I think Dr. Panda and Dr. Varsha, you can both fight along this, and I would be the referee. Yeah. So anyways, on a lighter note, so as Dr. Panda said, in metabolic diseases, you see a level of around 50. And Dr. Varsha, what is your thoughts on this reaching to a level of around 50? We'll talk how we can reach to that level, but reaching to a level of around 50 in this condition, especially in metabolic syndrome patients, how do you see this as a going forward therapy?
So I stand by my previous statement that we are not monitoring the levels. I am not reaching a particular target zone. I am treating vitamin D for skeletal benefits. I am treating vitamin D in a pre-diabetic person. Yes, but if you ask me, like every type 2 diabetic or your otherwise a person who's coming to your OPD with as Panda sir said, vague symptoms, and the vitamin D levels comes out to be on a lower side. It's not that you're not treating the patient, but I'm not going to monitor a post treatment vitamin D and say that, okay, no, let's go above the zone of 50 and we are not near we are only at 25 and 30 and let's now go increase the dose further and get you to 50. So, uh, monitoring a particular level of vitamin D and targeting that zone, we would do it in selected patients. Someone who is presenting to us with osteomalacia, rickets, and being endocrinologist, we get lot many of those metabolic bone disorder patients. Someone who is, say a sarcoid patient whom I don't want to land that patient into hypercalcemia, and where I'm careful that I want to keep my vitamin D in the zone of 15 to 20 and not really go more than that. So these are the patients where I would actually monitor the levels. Otherwise, I don't really monitor the levels on treatment for routinely for our other patients.
Yeah, Dr. Panda, you can add.
Yeah. That's a very rational approach. As I told, the last word has not been uttered in vitamin D therapy. We have to just titrate this in a with a very open mind and see exactly what is happening. We should not draw very strict labels, strict conclusions regarding the levels, the effects, and the outcomes. So we have to follow up the patient to get the result, and because there are issues related to toxicity, it's only more than 100. We have to be careful, and we can continue supportive therapy with this level.
Yeah, I think Dr. Varsha has some another meeting, so she would not be able to join again. So, anyways, we can continue with our discussion, Doctor. So, what I think is, as Dr. Varsha rightly mentioned, but some of the things that I agree on is especially for the nephro part, where actually this thought came for the levels is actually from one of the nephrologists I met. So he said me that when you are treating SHPT, a level of around 30 is of no use because you don't get the optimal SHBT suppression at a level of
In many
at a level of
conditions,
30.
all the
Yeah,
conditions I told, starting from psoriasis, the pre-diabetes, the PCOS, and then even patients of skeletal indications. Though 30 was the level they were telling its sufficiency, but we have not got therapeutic benefit at 30. As I
true,
told, that's why we keep a target of 50.
true. This I think so, sir. You may better correct me on this. I think one of the major reason for this may be an invisible adiposity, especially for Indians. I think that would be one of the reason
Yeah,
that even if we are reaching to a level of around 30, which is seen in the blood, majority it would be sesquipedal at the adipose tissue. Maybe one of the reason. I'm not very sure, but just putting out some hypothesis from my
yeah,
pharmacology days.
yeah, that can be. That can be because we have a average BMI is high, and we are the third obese
True,
country in the world, and especially in women, the obesity is more than that of the men. So we have to keep this in mind and see the gender difference and see the ethnic difference and
true.
systematically study this.
Now, sir, moving on to how we can reach to that level. So, how you approach reaching to a level of 50 nanogram per ml weekly, daily, or how is your routine practice with respect to vitamin?
Yeah, if there are no contraindications for the oral administrations, what I do, I go for daily administration for consecutive 10 days, and then I give it weekly for consecutive 3 months, and then we give monthly for rest of the time. We usually don't stop. So initially, when it's less than 20 or very low, we assess the level, and if it's very low, after around 10 days daily therapy, we make it weekly and monthly, and giving the injection of 6 lakh weekly is not advocated because that will cause the hypervitaminosis. So in case the injection is available and the patient is willing, we can give one shot in a year and continue a maintenance dose of weekly for 12 weeks and monthly thereafter. But even if 3 months, 6 months, or 1 year you stop, they again run hypovitaminosis. And I have seen that people in whom we discontinue, they again come with levels less than 20 and they are symptomatic with different uh, associated metabolic and skeletal issues.
You prefer a daily therapy of 10 days followed up by weekly. That is
Weekly
what
for
correct.
3 months, 12 capsules of 60,000. And then monthly we continue. And I ask my metabolic metabolism associated disorders like diabetes, hypertension, obesity, dyslipidemia, hypothyroid not to stop, to
Okay.
continue it, and in between we verify the serum calcium level and serum vitamin D3 level every 6 months, 1 year we do.
So you prefer a daily therapy anyway. So what I have seen, sir, what literature says is that when you start with a daily therapy without any loading dose, because you are providing a loading dose of 10 days. If you start without any loading dose, you don't get to a level of around 40 or 45 enough with only weekly therapy.
Usually I give loading dose of 6 lakhs injectable, and then we continue with this regimen. But in between, the injectable therapy was not available, and not available in
True.
many places also. And there are many patients who are very scared for the injection for a non-emergent condition. Suppose they have vomiting, fever, or convulsion, they're agreeing. But vitamin D3, that will sir oral दे दीजिए. In
True.
COVID time, we are following daily for 3 days, then weekly. And now, for those chronic diseases, we continue it for 10 days. COVID, we had a regimen of 3 days daily, and then weekly we're continuing during the pandemic.
So we have also proved it in our study that weekly therapy of 10 days is far superior than giving it at a bolus dose of intramuscular injection. So we showed superiority over intramuscular injection. And anyways, I was of the thought that intramuscular injection never gives you a superior rise. This may be one of the reasons that when you take orally, it directly goes into the lymphatic system and directly to the liver to hydroxylate. Whereas when you go give it as an intramuscular injection, it goes to the blood and then it goes through the whole circulation and goes to the liver for hydroxylation. And we measure 25 hydroxy. So anyways, it would show a little, what you say, a rise in the 25 hydroxy would be little slow with the intramuscular injection as compared to oral. You may better add to this, sir.
Yeah. That's well taken. That is evidence-based, and we can accept that.
Now, sir, just moving on to some of my last points or thoughts on this is that Nanocarrier anti-vitamin D, what Pulse Pharmaceuticals has developed, especially for patients who are unable to get the desired level with your capsules, granules, your conventional therapy. So we
Yeah.
have made this for everyone. So we see a very minimal variability among patient to patient, which is generally very high in terms of conventional preparations. And we, as a company, are delivered for the patient's improvement or patient's health. So what I am assuming is many of the patients that you may see in your clinic as a metabolic syndrome patient is generally suffering from exocrine insufficiency or deficiency, because not only the endocrine part of the pancreas but also the exocrine part, which is responsible for your fat absorption, is also hindered, which is
Yeah.
your exocrine
Yeah.
pancreatic insufficiency.
Yeah, that's rational, and the preparation is has an indication, and
True.
we only when we use for some time and get the effect of it and document the outcome, we can tell more about the nano preparations. But at present, in this scenario, this is a evidence-based preparation and should be procured in patients who are indicated for that.
True. Means you can freely give it in metabolic syndrome patients
Metabolism.
over your capsules and granules because of the exocrine part, I
Yeah.
can see.
Yeah.
So yes, so just adding to this thing, how you see this going into the cardio segment, because most of the audience today is a cardiology background. So I think most of them has a confusion that why vitamin D in the cardio space, and secondly, some of the trials that are done, especially the vital trial, which showed a negative impact of vitamin D on health outcome. This may be one of the reasons that the level was not achieved with the vitamin D supplementation. You may better add, sir, what should be the go-through plan for a cardiologist?
Yeah, there are evidences of vitamin D deficiency directly connected to atherosclerotic cardiovascular disease as well as heart failure. So, for cardiologists, those who have risk factors like smokers, obese people, type 2 diabetes, hypertensive, dyslipidemic, family history of coronary artery disease, as well as patients who have run a high risk of heart failure with preserved ejection fraction or reduced ejection fraction, they should receive vitamin D prophylaxis, because that not only increases the level and ameliorates the symptom, that affects the long-term motility and morbidity. We have evidence towards that. So, in that case, a addition of a vitamin D3 in a suitable preparation and the regimen will be definitely productive. And it's not that this is empirical and not evidence based. This evidence based in these two situations I told, the atherosclerotic cardiovascular disease and heart failure.
I think also for most of the cardiology, the go-through point is statins, and statin-induced myalgia and vitamin D has a big history. So I think that can also be one of the indication to go
Yeah,
through.
yeah. Invariably, they get statin not only in low dose but in very high dose.
Yeah.
They get the preparation. So adding this is evidence-based and should be practiced.
True. Now, I would just request OrthoTV, if there is any questions, they can just forward it to both of us so that we can take up some questions if there is any from the audience.
Okay, sir. Please wait. I will send to you. Please wait, sir.
I think we have discussed enough. We have touched every aspect. So even if there are questions, they must have been answered by now.
I th- I think it was such an elaborative sessions by you, and Dr. Varsha also highlighted some of the points that were I think the new endocrine society guideline. I think most of us were not aware of. So I think that was Ortho TV is putting some just a sec. See to it. Okay, so we have a question, sir. Continuously daily for 10 days or 7 days, how to decide? I think I can take up this question. You can, sir, you can just better ask,
No, no.
you can better answer, and then I will
There,
take.
there is no evidence. As I told, we have given 3 days during COVID time. We have used for 7 days also. But optimally, when somebody is not receiving the injectable, we saw that 10 days consecutive therapy of 60,000 helps us achieving the levels of 50 plus early. So that was decided. And as I told, there is no last word, no strict guideline, no differentiation in giving less or giving more. It's not that if you give 10 days, there will be hypervitaminosis and 7 days will be hypo. It's not uttered. You can practice 7 days also, but you have to achieve the 50 as early as possible for the therapeutic
True.
benefits.
We at Pulse have done the trial of both 10 and 7 days. What we have found out that after 10 days, the level is around 96, whereas after 7, it was around 55. So I think it is better explained then. If you want a level of around 80, so you can go for a severely deficient patient, you can go for around 10, and for deficient or for insufficient, you can go for around 7. You may agree, sir.
Yeah. And that makes a sense.
Sir, how often one should check vitamin D levels? It's very costly. This is very practical question, sir.
We test every 3 months the deficient patients, and those who once go to sufficient levels and patient is on therapy, and then we evaluate 6 months or yearly. That is the
Okay.
regimen we follow.
Okay. So, and sir, next question, I would take up this question. Any difference between Deksel and innovator brand Depura? So, Deksel and Depura. Actually, the innovator brand is not Depura. Innovator brand is Deksel. Pulse Pharmaceuticals is giving to Sanofi Limited as well as the name of Depura, and we are making it for ourselves as well in the name of Deksel. So we are actually the innovators, and the Depura is one of the assignments that we are doing for Sanofi Pharma. So that's all, I think. Any more questions? So I think, sir, you can just summarize the points, and then I can give a vote of thanks, and then we can conclude the session.
Yeah. Actually, the summary of hypovitaminosis D3 or deficiency of 125 dihydroxycholecalciferol is, as a ethnic region, Indians are deficient in vitamin D3. So anybody who has a chronic disease, maybe diabetes, maybe a collagen vascular disease, maybe psoriasis, maybe PCOS, maybe obesity, as a part of prophylactic correction, you have to maintain a vitamin D3 of adequate level, say more than 50 or say between 50 to 100 to get optimal benefits. And the patients are to be guided regarding their diet, lifestyle. Many times we give vitamin D3 and don't tell them the food rich in vitamin D3, don't tell about sunlight with the UV exposure, don't tell about the exercise and the practices which increase vitamin D3 level. So that lifestyle should be insisted along with supplementation. And because this is a correctable association, this may not be a very therapeutically very important target, but in chronic condition for a optimal health and quality of life, this is a correctable parameter. We should go for the correction, maintaining a satisfactory vitamin D3 level, which will keep our patients healthy. And even if you do one level 6 months or 1 year, that is sufficient to see whether you are maintaining it. But in deficient patients, we have to monitor more frequently to see whether the level is corrected or patient wants injectable or daily therapy to be given for longer period. So in all the indications discussed, the skeletal, non-skeletal, the metabolic, non-metabolic, and especially in chronic conditions, you remember this condition, and assessing as a routine test in the first exposure and planning its correction is not without evidence in our Indian patients.
I would just I would just do a one-line summary of this, is that you should not just check this thing, but if you are checking and if you are found to be deficient, just don't reach the 30, reach 50. That's the thing, I think, what
Yeah.
you want to communicate.
Yeah.
So I think that it's already past 27 minutes as our time. So I think I would just conclude this sessions, because we are also having a very exciting Euro quarterfinal coming up for Germany versus Spain. So I think most of the audience is waiting for that. So anyways, I would like to conclude this ceremony. So this was such an interactive and such a, bombarding session of vitamin D. I think most of us now would be bombarded for 50 nanogram per ml. And Professor Dr. Jayant Panda, I was delighted to have you on board, sir, along with Dr. Varsha Jagtap, who could unfortunately is not able to join again. But anyways, I would now again just give a vote of thanks to my marketing team, the whole of the marketing team, and to whole of the sales team, right from my executive to my business unit, Mr. Raghu, and also to my marketing again, Mr. Alok Verma, and to my president, Mr. Samar Ghosh, and finally to you, sir, for being there, for helping us go through this very easily, and for navigating us through vitamin D and its important in various therapies. So it was a delightful session, sir. Thank you, sir.
Thank you,
joining,
Dr.
and
Ashnat.
it was a delight. It was a delight, sir. Thank you, sir.
Bye.
We'll meet.
Bye.
Thank you.
Bye.
Thank you, sir. Bye. Thank you, audience, for joining. You may close the session now.